Cloud. Hello and welcome to the kickoff to our Return to Care QI project for the Dallas region. We're so excited to be putting this together. As you'll be seeing and hearing over the course of today, this has been a labor of love and a work in progress by the AACQM team for quite a bit. So we're really excited to have you on the line with us to share this project with you, to roll it out, to let you know the expectations so that we can do something all together as a group. Very, very exciting.
All right. As Michael said, we are so excited about this project because this is something that has format, has a process, not just to start, but the ongoing follow-up and evaluate data at the end to be able to present something solid. And talking about being solid is, okay, you can have this training series recorded in this link in the YouTube or the training series toolkit that we sent. As you can see, it's everything more formatted, easy access for any newcomer into your agency who would want to join CQM. Boom, you can have the easy, quick board into that person into this links. And we have in the line Sonia Hughes, so our assistant director support. She's been very crucial in this developing, remodeling CQM around the region in Dallas, EMA and HSDA. And I passed the word of the microphone to Sonia. Sonia, good morning.
Good morning, everybody. And again, I'm happy to join and happy that you all are here and as excited as we are about this project. So, you know, definitely kudos to our.
Can y'all hear me? I'm not sure if I'm on.
Uh-oh.
I hear you.
Who is that speaking? But again, just thank you for joining today. And we all are very excited about this project. So yes, we're excited to get the training rolling.
Beautiful, thank you so much. And if you are not a part of Glass Cubes and don't know, you know, what we were talking about in terms of the repository, just reply to the email that we'll be sending in follow up to today's webinar, and we'll go ahead and add you to Glass Cubes. It's the place where you can find all the toolkits at once. So you don't have to fish through your email. And the YouTube, of course, as Oscar said, is available to everybody. So I don't think we have Angie with us today. So Regina, would you like to cover this?
Sure. Good morning, everyone. With the Zoom meeting, we will, if you need to adjust everything we have, you can press escape to exit the full screen on your computers or laptops or tablets, whatever you have in front of you. You can hover over the top to change your view if you're viewing options. You can also place yourselves on mute until you're ready to pose a question. We just ask that if you could please to minimize the background noise. And then also you can use the chat if you'd like to pose a question or make any comments during the meeting. And this meeting will be recorded, as Michael said earlier. It will be recorded for you to go back if you miss some information or need to go and share it with your staff. Thank you. And there's Oscar there showing you where your mute button is, sharing that. And Angie is showing you where you can share your video. And there is Jamie, if you'd like to show your chat with everyone. And Oscar is sharing our view, where you can change your view, how you're viewing everyone. And there's a team sharing with you everywhere, all of the team, and especially me. there
you gotta get your mug on this slide. Thank you for that. Thank you. And as we'd mentioned before for the toolkit, and I forgot to mention this, we'll be sending an email for everyone who registered. So if you came in and had to change your name because you were listed as Julie or Sonia, that's okay. Just make sure that you drop your email in the chat room so that we know who to send the toolkit to afterwards, because we want to make sure that you all have that.
And really quick, whoever's on from HIV Care Services, if you could please correct the name so we know who's here. I still see Julie, and I know there's two of you that are not me. So please correct your name in the chat if you don't know how to do it. It's up here. There's 3 little blue dots. You just click on it and you can edit your name.
Yep.
Thanks.
When you're talking, there's a little green box around your face, or the box that represents you. That's where the green dots are. You can also do it by clicking participants, and where it says me, it'll say Julie Saber me, even if your name is Chuck. You'll just want to click more and then change your name. So a couple ways to do that, and you got support here if you're looking for help. So one thing that many of you may have noticed. Oh, actually, Regina, would you like to cover these as well?
Helps if I'm off mute. Okay, sure. Sure. Okay, so once you join the session, and as Michael stated earlier as well, we'll be adding your agency name. So as Julie mentioned as well, please correct your name, and so we can know who we have represented. This allows us to facilitate assigning you to appropriate breakout sessions during the training as well. If you would like to add additional information such as pronouns, which we encourage, please do not erase your agency name. And then if you get disconnected and have to rejoin without your agency name, we'll add it back for you. Thank you. Okay, and that's me as well. Okay, so you're being tagged, so you can be assigned to your group, and then also we're asking you will get an opportunity. It's going to pop up when it's time for us to go to our breakout sessions. You will have the opportunity to pop up and say breakout, which you'll see there, and you just click on join. Sometimes it may not pop up directly on your screen. You may have to navigate around and look on your screen but you will have an opportunity to press join. When the time is up, you'll be notified, and then you'll be asked to rejoin the main group. And I think it actually automatically pops you back in, even if you don't click to join the main group again.
That's right. Thanks, Regina, and thanks for stepping in while Angie's taking care of family. So our learning objectives for today, let's begin the show. What we'd like you to do at the end of today's call is to be able to describe what is this project that we're rolling out for the EMA and HSD-wide project for the year. We want you to think about that specifically based on the services that are provided by your organization, because we're going to have to be creative in finding ways for our organizations to meaningfully and productively fit into the project. We'll want you to complete QI project planning with your teams based on an action plan or an action form at your agencies. And this is basically to practice everything that we've been talking about so far. So in September, we had talked about QI process. Oscar had mentioned we have the recording for that. So, there are those resources from before, but we're going to be walking through that process now using an actual project for a whole region. We'll want you to have data. We'll want you to involve your stakeholders. We'll want you to think about where you want to make your effort as an agency. We'll ask you to generate a root cause analysis and primary drivers for the aim that you select based on your discovery process. And if possible, to begin identifying change ideas appropriate to address your drivers. Now, we're going to be talking about how this is spread out. So I don't want you to see these 3 subpoints here and be like, wow, that's an awful lot to do in a short period of time. This is going to be a sane, practical process where we're all practicing how to do this together since it's our first time. So that's our learning objectives for today. Introduce you to the project and to let you know what our expectations of you so that you're able to move forward at your home agency and to make a dent in this. As we'd mentioned, the toolkit will come to you probably later today or early tomorrow, and it'll include the charter that the AA has put together to describe the project. There's also a frequently asked questions document that will be circulated and the logic model that shows you what this project is and what it's supposed to achieve within our region over the course of the next 9 to 12 months. There is a little curriculum that goes, so you'll see today's webinar included, but all of the other webinars that will come through this. We're going to be talking about this throughout the day, but this is just an additional handout for you to have in discussing with your staff and other relevant people as you're involving in your QI process and your project at home, because you might have different folks you bring to different webinars, or who you want to send the links to following the webinar, depending on your style and your staffing and how your agency works. And of course, since we have these new forms to be able to talk about what we're actually doing in quality and in this project at our sites, we're going to be sending you the form and then also some instructions to include as well. And one last thing about this is, this again seems like a lot of kind of action-oriented and work deliverable type of materials. That's because there are some here. But the important thing to keep in mind is you are not alone. Dr. Salinas' team, Jamie and I are available, as you'll hear and see throughout today's webinar, to provide hands-on coaching to your agency so that your agency gets it and knows how to move forward in a way that is in step with this project. So no one is alone. No one's going to be exposed or left in the cold. This is something for all 12 of our organizations to do together. Oscar, would you like to say something?
Yeah, and I would like to add something on the process of, okay, we all on this together is basically the point. I mean, no one is not doing a project that involved the return to care for the region, because that is the population that actually left out and is the one to keep the ball rolling into bringing more clients into the pile. I mean, it's just interesting how the process can be decreased if we address these people return to care, why they didn't come back to care, why they didn't stay. Can we move our model? Can we stay? New ideas are coming out of the projects such as this. And you know, because you've been on this for a while, some of you are more, I mean, legendary on this, Ryan White, but every agency works different. That's why the model can be modified. That's why the external CQN committee chair, Dr. Maurice Harris, who is with us, recommend, okay, let's do this project in this modality. We recommend to do this. So we have the support of the consumer. We have the support for the providers. We have the support for anybody who is inside the team is welcome, that support. Please bring us that new ideas. Thank you, Michael and Jamie.
Thank you. And, you know, Dr. Salinas and all of us are so excited about this project, and we'll be sharing with you more details as we go. But for now, I'm going to turn it over to Jamie, who's going to just help us with a little review.
Yeah, thanks, Michael, and thank you everyone for the opening words. You know, we've talked a lot in our training series so far about sort of some of the principles and theories and concepts of CQM activities, and so there's sort of just a quick reminder of what that methodology is and how that structure is helpful to us, and then we'll concretely kind of dive into this particular project and where those pieces complement the stuff you'll find in the toolkit, and also kind of wrap up with some time for breakouts and action planning. So that you can kind of think about the things most relevant at your agency. So we can go to the next slide. Awesome. So just as a reminder, you know, we find in policy clarification 1502 and other pieces that quality improvement projects, you know, they are required. And so I think this is there's some collective momentum, right, in us aligning and doing projects and having this going for us. This is actually a kind of very celebratory thing, and I hope it makes you feel good. It makes me feel good. And so, you know, as Oscar was mentioning, we do have a methodology, and as Michael said, you know, all of this doesn't have to be done in one day, but we are going to follow the model for improvement because that is the EMA HSDA preferred methodology. And we do have some also expectations for alignment across our QIP projects within our contracts. So this is sort of a lot of things coalescing, I think, for the good and for the better. And, you know, on the other end, we have sort of the models and the frameworks and the expectation to create alignment within our quality improvement projects. But we also have complementary to that, the organizational assessment, which is a form of evaluation. And there's a lot of pieces within that talk about What do folks do with their QI projects? What informs them? How do they test their change? And so you'll see pieces baked into today's presentation that will also stand in good favor in terms of how we evaluate and assess our projects in the directions that, that we're headed. We can go to the next slide. So again, you see here on the right, this is that visual depiction of the model for improvement. A lot of folks may say, I'm kind of familiar with the Plan, Do, Study, Act, the PDSA part, but what we really want to emphasize are also those 3 strategic questions that then become followed by the PDSA cycle. So it's really the questions and the PDSA cycle that encapsulate things. We'll talk a little bit about, you know, how we ask ourselves, what are we trying to accomplish? How we know that change is actually an improvement? And then what change can we make that will result in improvement? So part of the discovery process is sort of QIP project lifecycle. That's where you're going to be setting your aims. And so this is going to be something over the course of time that your agency will work on, is establishing an aim for this QI project. And then we also sort of flesh out which measures and what data points are going to be necessary. And we can take some of that from our discovery learning. And then with our root cause analysis and sort of digging into the why we're experiencing no-show appointments or folks not being engaged in care, looking at those root causes help us identify what tests of change we want to start with first. And then you actually do the stuff, right? You begin implementing those various tests of change. We can go to the next slide. So I think we have a couple of different ways of presenting this QIP project lifecycle. So again, within the discovery, that's where you're going to assess. You're going to diagnose through your root cause analysis and change ideas, and then you hit that green light, and we begin to intervene by implementing our tests of change. We can go to the next slide. This is another way of speaking to the same pieces, right? So what is this QI project life cycle? And over the coming months, what are we all sort of doing collectively within our respective agencies? So we begin with discovery, and you see there at the top left, we have the aim, sort of the issue to consider. And again, you'll be kind of crafting your own aim statements, which are really kind of SMART goals that sort of help set the vision, and you know where you're headed. They're succinct and concrete. We begin sort of brainstorming and consolidating data. You know, what data points do we need for discovery? What data points do we want to make sure we have a pulse on to check if our change is in fact leading to improvement? And then we get into root cause analysis, which is my absolute most favorite part, especially if you're a visual learner. You can have a lot of fun utilizing tools, I call them QI solution tools, such as a fishbone diagram or driver diagram. We can look at our process maps or flow charts to sort of capture what our current state is. And then toward the end of implementing our tests of change, we can see, how that process was maybe impacted. So throughout that root cause, you do your QI solution tools, and then you consider the data or input of different consumer groups or other stakeholders. And then we begin to translate that information. And through implementing change, that's where you look at as the data or the step measures or things come in, sort of what's being effective, what's changing. And like, as I mentioned, you can then develop a new flow chart to sort of say, hey, here's what our care looks like now. And here's all the sort of interventions or things we've implemented. So that's just another way of breaking down that process. So let's talk a little bit of recipes for success. Something that's really, really key is to make sure that you have robust stakeholder involvement. This is not one person's job. The aim, the discovery, all of that, it's not the quality manager, it's not just the quality manager and the data manager, but you want to make sure you have robust stakeholder involvement, which includes, who you draw in to help brainstorm on root cause analysis. And it also relates to how you communicate progress and sticking points. But again, you're not alone. So throughout this QIP project lifecycle, we have some good prompts and some good action planning to help you think about baking in these different recipes for success. That would also include sort of your strategic alignment. And we talked a little bit earlier today about how alignment, has its role and plays its part within these projects. Things that we've seen, in our time are definitely some common challenges. We got to always sort of keep an active mind in separating what is quality assurance and what is quality improvement. They are not the same thing, but they often get a little confused. So remediation for low performance, this is not about taking a low performance measure and trying to get in compliance or trying to beef it up to where it needs to be. This is also not addressing site visit findings. This is sort of taking a way to elevate your health outcomes, and quality improvement is focused on sort of continuously amping up or improving those health outcomes and making sure we're doing it through identifying disparities, right? And we're really digging into where this needs, where we would benefit from seeing this happen. We want to be sure that we resist the urge to kind of constantly run around and put out fires. Having a culture of quality and having a clinical quality management infrastructure and these projects is important to the work we do. And one thing that we also see that happens a lot is this idea of never-ending projects. So throughout the training series and with the support of the AA team or Michael, myself, and other folks, we can help you figure out, how do I adopt or abandon and move on? We can go to the next slide. I'll turn it over to Michael to move us through the next part of the presentation.
Fabulous. Thank you so much for that quick review, Jamie. It's so helpful to just have that reminder of, the model for improvement, our life cycle, and, a couple of those strategic questions. And just again, for those of you who didn't see the full presentation from September, we have it saved on the YouTube channel and all of our past presentations as well. So this section is looking at why return to care, right? So we have talked about discovery processes and you're at the provider level, but we're representing the AA. So what we want to do now is to walk you through what process the AA used to develop return to care, so that you have a sense, well, why are we focused on this and where did it come from, considering everything else that we could be doing? So of course, I'm going to start with a poll. And the questions are simple. Has your HIV service organization completed an analysis of the clinical care engagement for the clients it served in the last 6 months? And do you believe that your HIV service organization will be able to affect the clients you serve and their ability to remain engaged in HIV ongoing care? So what we want you to do is to think about, have you done a discovery analysis of your own medical engagement data? And that's a trick question, right? Because it might be a little harder for some of you who are supportive agencies, but this is, the question is a question. Have you done a discovery process or an assessment of where your folks are at in terms of their medical engagement? And then 2, do you think that your agency is positioned to actually make a difference on this? So I'll wait just a moment. We have about 1/3 of the votes in. And we appreciate honesty, and, if you're not sure, it's okay also. Okay, I'll leave it open for about another 5 seconds. 2, 1. All right, so let's share what we got. So most of us have actually done this. That is fabulous. That means that 59% of you who responded to this should be able to take the data that you have available and only append or add a little bit of data, which is what the AA did. The AA had a lot of data available, but it needed to find a little bit more in order to make the determination to focus on this project. For those of you who haven't done it, this is a space where the AA CQM team and Jamie and I would be able to come in through calls, virtually still, right? To be able to help you to think about what you would need to include in that analysis so that you can engage your stakeholders. You have the data, you're ready to engage your stakeholders. Do you believe that you'll be able to make a difference? Most of you say yes. One of you said no. And again, I appreciate that honesty, because a lot of times it seems really nebulous, right? When we think about, how does my agency that does this one small element of care affect all of this other stuff that's very concrete and clinical? Doesn't it feel like the tail wagging the dog? And we're going to be addressing this issue as we work our way through today's webinar and in future webinars. And there will definitely be coaching to help you design and deliver your project with that in mind. So this is the why behind the what. And as I'd mentioned that before, the AA had its own data available. And so even before COVID-19 in 2020, it was expected that more than half of all the people receiving funded OAHS services at our subrecipients would miss at least 20% of their visits. So half of people are missing 20% of their visits. And that's not even considering COVID. With COVID, we had even more disruption and even more issues with our care constancy for our patients. I know myself as a person living with HIV, I had my provider barking at me to come in. So we get it. The average rate for missed appointments for all of the American healthcare setting at large is 18%. So we wanted to pick this because one, care constancy is tied to viral suppression. It's also tied to care constancy is retention. It's tied to suppression, and it's also related to people's appointment keeping and health seeking behavior. And in light of our population and in a pandemic, it's really important that our clients feel able to access that information and that there is a high level of health seeking behavior. So, with COVID, this becomes even more of an important red line for us to fix. According to the data produced by the AA, the high proportion of missed visits is contributing to a low regional viral load of 62%. And this is based on ARIES data that Oscar's team went through over and over again with Thomas at the AA. So we are focusing on retention in care, right? And so this is also our first project. So what we wanted to do is to pick a topic that is an important topic. And this is always an important topic, right? Retention is something that appears in so many HIV priority initiatives. So we've talked about Achieving Together quite a bit in Texas because it's our statewide HIV priority initiative. But there's also the Integrated Plan for HIV Prevention and Treatment, has a focus on maintaining care constancy. The National HIV/AIDS Strategy also mentions retention in care, particularly disparities, addressing disparities. US EHE, which we're in EHE Priority 1 jurisdiction, also mentions retention and also mentions disparities. Fast Track Cities, guess what? Focused on retention, focused on disparities. And 90-90-90, retention is implicit in the last two 90s. So thinking about this, we're not picking a topic that is out in left field. This topic is one that is very well established in the HIV service system nationally, and is one that is easy to plug into. Another thing that's really important to remember is that we should be working more as a healthcare neighborhood. A lot of folks and agencies traditionally look at the patients that they serve and they call them their clients. This is my client, that's your client. And what we're trying to do here is to try to disrupt that thinking and try to shift the ball so that clients aren't owned by any one agency, they're cared for by a collection of agencies. And so all the agencies serving the client have some degree to which they, have ownership over that client's outcomes. But that idea, that mentality that this is my client is something that can be really hard. And I'm sure that for those of you who have tackled this conversation, it can be really uncomfortable actually too, in terms of meeting client needs, assessing client needs, and serving and addressing client needs. So coordinating the client care should help to ease burdens on providers and their patients when we are thinking more as a healthcare neighborhood and we're thinking holistically about our patients and their needs. And it's not just about, well, I'm the dental provider, so I'm only focused on dental care, or I'm the case manager, so I'm only focused on case management. A position like a case manager is actually designed to help to coordinate care. Non-medical does one set of activities and medical does another set of activities that's more clinically focused. But the idea here is that even legal services, the medical legal partnership in Dallas has a role in coordinating the care and services that are provided to clients. Even if that role is to say, like, we just want to make sure that you have a doctor. So thinking about the referral management and communication with patients, assessing where there are gaps. Not that you're the expert, but knowing what you can do when you find a gap, what resources you have that you can give to the client to fill that gap, but also not exposing yourself and making yourself into an expert that you're not. This also helps to streamline workflows and align care philosophies across provider agencies. In our region, we have, it's a pretty expansive region, but there are different pockets of culture, of expectations, of need. And so in understanding where our points of service are near other organizations' points of service, we can help to streamline the workflows of where we share a lot of clients in common and what those needs tend to be and how we can communicate more routinely about that. This can also help us get ahead of funding stream issues. When we coordinate at this level, I've seen organizations team up to apply for Part C or Part D together, or they team up to apply for specific combined new programs. I know that we've had some mergers in our region recently, but this is thinking that you don't necessarily always have to go that far to fill a gap or meet a need that you share in common with another agency expressed by your clients. Instead, it's about identifying whether or not it's possible for you to both apply for a new Part B grant or a Part A grant or other grants. So this diagram is complicated, but the idea here is that the medical neighborhood in the center encompasses all the different services on the right. And we have a number of other environmental factors and groups on the left that can help us. And I think a lot of times in our HIV service system, we are aware of these other folks on the left. We kind of scorn them, especially, well, what am I going to do at the school when we're not allowed to talk about condoms or we're not allowed to do this? The idea is constantly trying to do the best and the most that you can and not allowing the different barriers to be the reason why you pack up for the day and go home. So this, of course, brings in our achieving together, and achieving together is so closely aligned with other activities that let's just focus on achieving together as our statewide goal here. It's our community plan to end the HIV epidemic. And based on what we were just talking about with our healthcare neighborhoods, this is actually how we access and tap into those social determinants of health. When you look at this framework that our partners with the state have created, they've included these opportunities for us to be status neutral and to identify mental health, substance use issues that are faced by our clients. Some things are focused on income level and income justice. Other issues are focused on housing, educational level, and how we can help to develop our population and bring them out of poverty as a whole through enriching them and giving them real opportunity, not just you know, a speaker's fee, but like real opportunities. Criminal justice and thinking about criminalization, some of the issues around immigration and whatnot. Again, this isn't to say that we are the experts that will solve all of the world's problems. This is having an understanding of those real issues that face your clients, and then finding partners in the field in your healthcare neighborhood who are wanting or able to address these same issues alongside you. And in fact, many of us are funded specifically to address these specific social determinants of health. And of course, we can't forget demographics. We can't forget, you know, issues related to race, issues related to gender identity, thinking about our trans siblings. We have to keep in mind that also where people live, like that they may be coming from a very, very long distance to come to our services. Demographics are also really important to keep in mind here too. And of course, that's something that we can use to measure disparity, right? So the last thing I think that's really important to mention here is not only is this something that the data for our region speaks to us and indicates it's an important project, not only is this something that's really tightly aligned with all of these other projects that we're expected to be participating in some way, shape, or form, but this is also one where there's been an enormous amount of work already in the field. So we have so much evidence. In other words, we probably don't have to recreate too many wheels to identify change ideas that we want to test and implement. Instead, we can rely on HRSA, CDC, and NIH-funded projects and their giant workbooks and outputs, thinking about EBBIs and DEBBIs for our prevention, thinking about spins, thinking about other research. Academic research and special focus by NGOs is another set of material that we have available to us. So thinking about IAPAC and their strategies for improving engagement along the care continuum, thinking about NASDAD and his health and other population-specific issues. Of course, we have the National Minority AIDS Council and the things that they do. They're doing a lot of great work right now with consumer involvement. So thinking about how we can tap into all of these different factors. Some of them will be clinical, some of them will be operational, some of them will work, some of them won't work. This is going to be something that we're all testing a couple of things over the course of the year, easing into the water together. And of course, for those of you who provide OAHS services and have opted in, there is the Continued Access Technology Program. So for those medical providers, we've given a project or a change idea, and that's what they'll be testing and implementing. Whereas the rest of us, we're going to have to go through that discovery process to identify what we're going to be testing, as you'll hear in just a couple of moments. So by the end of this project, we expect that we'll reduce the no-show rate of our scheduled appointments by 10 percentage points to around 20%, because right now it's around 30% as a whole. We didn't provide that number earlier, but it's around 30%. So we want to bring overall our no-show rate to around 20. And we want to increase the rate that people living with HIV access medical visits by 25 percentage points. That's a big jump, to around 70% among all people living with HIV who are served by our outpatient ambulatory health services funded subrecipients. And we're hoping to achieve these by the end of the calendar year, or 12/31/2021. We want to establish a baseline for the degree to which our services drive excellent health outcomes. So we have our OAHS satisfaction data that we're unpacking currently, but we do have our new experience evaluation performance measures that we're rolling out right now that will help us to have this side information about, people's perspectives about medical case management, non-medical case management, medical transportation, and outreach. So we're able to have these very concrete things that we're looking at on the side while we're focused on our project front and center. We hope to be able to achieve viral suppression of 90% based on the QI project and Achieving Together. So the way that evaluation will work. So we're going to evaluate the QI projects based on the AA and the subrecipients, so 2 levels, ability to meet the objectives that we've listed and all of the expectations. So we'll kind of be looking at all the subrecipients independently and also the AA and the management of the process overall. We want performance measurement data and QIP progress information to be submitted to us, and we'll be talking about that in the next section. It'll be self-reported and cross-referenced with other information. So ARIES information and other information that we have available. As you'll hear, and to address the concerns, I'm seeing the chat room fill up. To address the concerns, we will be having you report on your own health services data that you collect in your health record system, so that avoids that confusion with ARIES. So we will be looking at ARIES to kind of help to check the numbers, but that's not really a basis of evaluation. Instead, we're comparing internally within the sample of submissions that you make. The results of the evaluation will be provided to all the funded subrecipients, to the Planning Council, to the task force, and of course, it'll be saved in the revamped website that the CQM team is putting together, and in glass cubes. Transparency, transparency, transparency. We want folks to know that we are paying attention, that we are active, and here is a result of all of our actions over the course of a year. And of course, as we work our way through, by the time we get to the midpoint of the summer, we'll have enough results available to share with our internal and external CQM committees to help us identify quality goals for 2021. So thinking about how we can have a discovery for our next project, we're going to get that going mid-year. We won't bore you with the details until it's time to roll out the next one. unless you happen to sit on one of those committees, and then you'll be hearing about it as we're standing this up. So I want to take down the slides to just see what folks think so far, and for us to work the chat room and to talk a little bit about this, where the project has come from and where we think it's going. Any thoughts?
I'm still muted, sorry. I think this is great because our challenge is we always collect the data. We just haven't been able to get a consensus of what is the first starting point to retaining people in care. So we know we can pull up patient IDs and we can see whether they're assigned a case manager or not. It's just coming up with a workflow. And I think we have hesitancy to get started because we want it to work right away. So I don't know. It's just been a lot of things here and there that have prevented us from actually getting started. So this is a great push. Just get some momentum.
Hey.
I appreciate that comment a lot because, you know, something that I think is important is QI allows you to fail forward, and it allows you to try something out, and documenting what happened that wasn't expected is just as useful. And, you know, you can always learn from each test of change, and that can be a different mindset. You know, depending on the setting. I think we all get hungry to know whatever we're doing is 100% going to be perfect from the jump. But that's not realistic as human beings, let alone professionals. But, you know, what I think quality and QI is there to do is to tease out the value in when it doesn't work, which can be, I think, a powerful thing. So I really appreciated that comment, Natasha.
And I love
Piper
that.
gives a thumbs up.
I love the fail forward because that's why I'm a fan of starting small, small incremental steps, because you don't know what works and what doesn't work. And it's also hard to see what works. I've seen projects in our agency succeed, but linking it back and doing the proper data analysis to actually test why something works is always a challenge. And I don't know even if that's necessary in QI. So I think it's helpful for us to have a committee and to have external consultants to also keep us on track, because depending on who you talk to, they'll say, well, it's not really an exact science. You know, it's not like, you know, in clinical research where you need to have everything super exact and super structured. So it's always just hard. It's hard to know what works and what to implement, and going beyond what sounds good and being data driven.
Great. All right. Well, let's pull the slides back up, and I'll turn it over to Jamie to talk a little bit about expectations.
Awesome. Right on. So let's just, we can go ahead and dive into sort of what does this timeline, where are we headed? So as Michael kind of mentioned in the previous section a little bit, you know, we have some of our OHS providers when we have the use of these continued tablet devices, which are pretty cool. So agencies can use these in a couple of different modalities. And again, a lot of the information you'll see in the slide decks will also be reflected in the project charter for quick reference. So these continued devices can be used at the agency level. Folks can use them sort of in a telehealth, you know, designated room or space. They can be used in sort of a telehealth or drive-in, drive-through fashion. And that can be for all clients, right? Ryan White or non-Ryan White. For the folks that want to take up the option to actually hand out some of those continued devices to individual clients, though that will be for Ryan White enrolled clients, but you know, you can be sort of at the client level, but it can also be utilized, as I mentioned, in a telehealth room or drive-through, sort of at an organizational level. You have definite options, and this is something to think through and talk through with your team. Subrecipient agencies, maybe who aren't our OHS fam, you know, we love you. You're part of that medical neighborhood. And as Michael mentioned, you know, we'll use the same sort of process of that discovery process and selecting the interventions. And we'll make sure that we find that, that sweet spot of alignment in terms of the HIV care continuum. And then subrecipients, y'all can expect to definitely get that support and coaching from AA folks, Oscar, Angie, Regina, and myself and Michael. So we are going to do a 12-month project. Again, this is led by, the leadership team that we have, our strong team we have within the AA folks, Oscar, Angie, and Regina. We've got all subrecipients conducting. And again, this is a big deal, right? Getting to do sort of a EMA, HSDA aligned project is a really big deal. So very excited to see what comes out of this. And ultimately, this project is going to allow us to sort of form a little cohort for the folks who have a no-show rate at our outpatient ambulatory sites that's greater than 20%. And again, the primary purpose, regardless of what funded service you do, regardless of the size and scope of your agency, is that we collectively make an impact on retention to care. We can go to the next slide. So here are some sort of main touch points. We're talking today, we're getting launched today, and we'll move into breakouts and some action planning so that when we meet again in June, we can talk about, where did your, agencies can kind of give an update in terms of that initial process, right? What is your aim and how did you kind of land there? What data did you maybe pull in, or stakeholder groups, and have folks start to talk about the discovery process. And we might be in slightly different phases at that point, but we want to sort of share out on the progress. In August, we'll meet again. And by then we hope to see folks at different stages of testing change. So some folks might be geared up to test the change. Some folks have maybe already done a couple of activities that they looked at, and they can sort of report out on the progress of those. What happened that was expected? What happened that was unexpected? What are they going to maybe adapt or roll into their next test of change? In November will be a lot similar. We'll obviously be further in the progress, but that'll kind of follow a similar structure to how we meet in August. And then the cool show, the really, really fun part, I think will also be the poster symposium, where you'll get help and support, but you'll sort of have a poster, so to speak, aka like a slide, but that really sort of captures the full life cycle of the QI project at your agency. And that is a really fun time to hear and learn from each other. And as someone who's done that before, it's also nice to kind of go back in time and think about all the incredible work that's been done and the different growth that you've gone through in terms of following that QI methodology in the life cycle process. So very excited, very, very, very excited for that. And so you can see where those different phases align with those dates. Thanks, Michael. All righty, so for our OAHS providers, and again, this is kind of the methodology, which is also located in the project charter. So we're looking at folks who are out of care based on all the reasons, Michael went over sort of in that middle part of today's presentation. So we want to look at folks who've maybe missed 20% of their scheduled appointments. Definitely generate kind of a workflow to identify sort of that in-care status and the maintenance of that in-care status. We've got our continued tablets. So then we think through how do we get those off the ground and how do we use them at their agency or get them in the hands of people. And so folks who are maybe not doing the continued access path, we're still going to utilize that same QIP project lifestyle framework where we have the root cause analysis related to not being engaged in care. And from there, we'll develop our different change ideas. So we want to have these things done by the end of June. And then we can begin to prioritize, kind of like Natasha said, where do we start? What do we do first? We can prioritize and begin conducting our tests of change. And that'll happen between July and December. So again, you're not alone. We've got a structure, we've got a roadmap, and I'm excited to see this unfold. For our non-OAHS fam, gonna have sort of a similar cadence. We will have folks generate a workflow. Again, it's all about identifying the in-care status and maintenance. Here we know there's gonna be some partnerships with our surveillance staff, right? So we definitely have that clinical level data. So there's some pieces, yeah, Julie, get it, girl. So there's gonna be some pieces that happen, throughout the course of this month to make sure we're all connected and we're able to facilitate those conversations in that part of the discovery process. Again, looking at root cause analysis and getting to utilize some of those really cool solution tools and engage different stakeholders. We'll look for that toward the end of June. And the same thing, begin prioritizing and implementing those tests of change from July through the end of the calendar year. a couple of quick pieces. We want to keep in mind that our annualized measures, sort of those big snapshots, they can really kind of act as bellwethers. So we do want to encourage folks to also look at disparities. Initial no-shows or retention might not look that bad. How do we dive into that? And I think I saw someone in the chat earlier also mentioning how, within outreach, that's where they maybe see a larger percentage of folks not retaining care. So diving into that, or as Michael mentioned, some of those different demographic pieces. So we want to not just look at the system overall, but we do want to allow ourselves to be a little bit more granular so we can identify those areas for opportunity. So alternatives to just using those sort of like wide capturing measures, that'll be covered in June. We'll kind of give you some support and talk about how to do that. So how do we focus on changes being made and their effects? How do we balance all other considerations? And keeping in mind that a time-limited focus is important, and that will help us in the work that we do as we think about long-term versus short-term data. Again, we have baseline data for discovery, and we've got a lot of different things coming in. Michael talked about the exciting work we've done with our experience evaluation, whether you be outpatient ambulatory, outreach, non-medical case management, or case management, transportation. We have those pieces of qualitative data sort of giving us those deeper issues and feeding into the system. So let's use that information, right? We can apply that work we've been doing. Again, that's some satisfaction, or even we can fold in the special focus group or key stakeholder interview processes. In terms of our quantitative data, as I mentioned on the last slide, thinking about disparities, and how do we utilize everything that we've got available, our EHR, ARIES, we're looking at utilization, sort of our counts and our access, but also our outcome data. Again, so we have with our QI tools, we have another visual depiction of the same process as you begin to think about discovery, root cause, and implementing change. How are we feeding in our quantitative and qualitative data? How are we utilizing our different stakeholder engagement? And this is going to be sort of the map that we follow in terms of what we use and how we apply the QI methodology framework to this return to care project. Expectations, we've talked a lot about what's happening at the site level, but we're part of this team too, right? So there are definitely some expectations for us as the AA staff. Part of that is to definitely champion and support this process, the why, the templates, the formats, and to do our best job of giving you the things that you need to make the work easier. So we've got some action planning templates. We've got some the quality improvement project form. There's going to be different things you'll see in the toolkit where we wanted to do this work for you so that you can think through the content and you can be just engaged in the process. And we also want to definitely support you with the capacity building, not only the previous series, but this sort of 4-part series specifically devoted to this return to care QI project. Also being timely and accountable in our reports and updates in our presentations, which includes the ICC and the ECC. Communication is key. Folks within the community, planning council, the task force, and everyone else. So we have some expectations for ourselves we wanted to be transparent and open about. And we also have folks and expectations across the board, even with some of our state-right partners. So we talked a little bit earlier about making sure people have, if they need linkages to surveillance data and other pieces, information based on anything out of ARIES. So we see that here, and we definitely have some times to that too. We want to make sure folks have that information by the end of this month so that we can move forward as we've kind of outlined and designed for ourselves. And so these might be pieces that come up in our breakouts as well, how we think through the interrelated working nature of the AA, subs, state, and everybody collectively together. And with that, I'll hand it over to Michael for another quick poll.
Fabulous job, Jamie. And I hope that helps to see how it takes a village, right? And this isn't just all about you, it's about us too, and how we support you. So we wanted to make sure that that was, apparent to you. Now, we've talked before, the first poll was about whether or not we have our data readiness. This piece is really about whether you have your stakeholders ready, right? Because we're gonna need to take whatever information we have, see if there's additional information we need to glean. And then the next step is to report this and share this with our groups. So does your organization's CQM committee contain the expertise needed to conduct the discovery process? And does your organization's CQM committee and available stakeholder pool contain the expertise you need to conduct a root cause analysis based on that data? It's not just enough to be like, here's the data. We got to do the so what part too, right? So just looking to see, like, do you think that your folks that you have available have the skills and are ready to do this? Because if not, guess what? We can help with that too. Of course, we have our trainings from last year that, you know, we can kind of segment into bite-sized pieces and share back with folks. There's a lot of stuff we have, so definitely be honest. Let us know what you feel. Do your team members have what they need to be able to be effective? And I'm going to wait a little bit longer for some more responses. Let us know your perspective on this, because this will help us to potentially target resources, you know, in our service area. And I'm checking the chat room while I'm waiting for folks to vote. I'm glad you like those bite-sized trainings. I know myself, when I worked at Whitman Walker, having those little 20-minute bite-sized pieces was really helpful for my staff, especially you're onboarding new folks, you're transitioning people. It can be really challenging to cram it all in, so those bite-sized pieces. All right, I'm going to end the polling now and share. So it looks like we feel, for the most part, that we're in good shape, that the people we're going to need to circle into the wagons to have these conversations are ready to do that and have those conversations with us, but not everybody. So it's really important that, you know, we'll be working with each of you, as we had mentioned. All of you will receive a courtesy call at the very minimum, but we anticipate that we'll be actually working with you to stand up some of these bits and pieces and to provide you with some advice as we work our way through. So just make sure, take those deep breaths. This is our first project. We are easing into the water. We purposely selected something that accomplishes multiple goals. Something that we didn't emphasize before is that, guess what? If you're doing a Create Equity project that's focused on retention, it counts. And we'll be able to work that work into this work so that we can talk about it all together. If you're already doing something else for your Part C or D funded agency that's related to retention and care, guess what? That works. And we'll be able to help you figure out how that fits in. We do not, I'm a person living with HIV who's been, you know, part of the service system for a long time. We do not expect people to do multiple competing projects. We do not expect you to like lose your mind and your hair working on these issues as we start out together. So this is something that we're all in it together. We'll all take the steps together, and we'll all hopefully have a bang out project by the end. So we are going to be breaking out into 3 different groups. We have one group that has our continued access folks, and everyone else is splitting into 2 groups. One group is a little bit more clinical, and the group, one group is one that is the medical legal partnership and legacy and legal. And I'm going to be working with you all to see what we can do for your project and to answer your questions. Really, the whole purpose is to walk through the next steps. If you're in continued, what do you need to make sure the devices come to you and get into the client's hands, or however you're doing it, and so on and so forth. So this is going to be probably just a quick 15-minute conversation that we have. I pre-split the breakout rooms based on my understanding. Some of you didn't have the agency afterwards, so you're just going to come into my room by default. We'll shift you around if needed, but I'm going to go ahead and open the rooms now. Is that okay, Jamie? All right, so stand by. I should have mentioned that if you're in my group, I'm a cheater and I'm not changing rooms. So you'll stay here with me. Not everyone's going to get that pop-up, but if you do, go ahead and click OK. And that will take us to the other rooms. All right, so I'm gonna trust that we are good. Each room has a person living with HIV. Each room has a state representative, and each room has a county representative from the AA outside of the team. So we should be in good shape here. Let me stop sharing these slides so I can see all of your beautiful faces and we can start working our way through the conversation. So my first question for you, if I can find it among all these other windows. Great. What challenges do you foresee in identifying populations to focus on your discovery phase? And I'm asking that not coyly, because I know that our group is special. Our group has some folks that don't necessarily always feel like, what skin do I have in the game of clinical care? So I want to know what your thoughts are. How ready do you feel to do this? What needs do you have? Does anyone want to go first? It's a breakout room for us to collectively workshop this together. So let's make good use of it.
Well, this is Helen Turner.
Yeah.
I don't work in a clinic. I'm a consumer advocate.
Yes.
And I work with many organizations. I've lived with, was diagnosed with AIDS 37 years ago. And so I also live in congregate housing at AIDS Services of Dallas. I see that Traswell Livingston just left the call. I wish he would still be on the call because we're doing some great things here, as I am a member of the CQM team representing consumers here at this organization. So when I answered yes on all those questions, I answered that because as a member of CQM for AIDS Services of Dallas, I see that we might not have everything in place, but we have the willingness to educate ourselves, and we're doing trainings every single month to make sure we can comply with all that is necessary. So I just wanted to say that, but giving other people an opportunity to speak now.
I love that.
I get a lot of complaints and input from clients from all these agencies, and we have issues. We were successful in getting, we have pretty good stats, CQM stats, but we were successful. Our medical case management was successful in getting the telehealth piece, that equipment into our organization, so that we can now have folk go into the medical case manager, get signed up, your doctor's on the other end, do the test, all the things that that will increase people attending their sessions because there's fear.
I appreciate you sharing that. I think Danny wants to share too, but real quick, Helen, I just want to ask, do you do different types of like experience evaluations, or how do you tap into the heart of the clients to figure out what's working for you, what's not working for you, what brings you to care, what is something that kind of keeps you at arm's length?
Well, we do surveys, and a pretty extensive survey. And we solicit the opinions of all the consumers. And we have 5 different buildings where there are consumers living with HIV. And so we do that. We even pay them to do the survey.
That's great.
Yeah, let someone else speak now.
Yeah, I'm one of the case managers at AIDS Services of Dallas. I'm Danny Edwards. I got to agree with Helen. We actually are doing a lot, and we was having a lot of problem with actually our clients returning to care when we got them to the building, because a lot of them, since they're considered as chronic homeless, it's hard for them to get back into care, and actually the trust as well. Our biggest problem in my building, I'm in the Hillcrest building, is actually dealing with a lot of my transgenders. They're the hardest ones to actually get back into care. But with the new machines we got now at work, it's actually much easier for our clients and the nurses to actually stay on top of all our clients now, which is actually great. Like Helen said, we do a lot of surveys with our clients just to see, where they are, what they expect, what they look for, and, how we're doing as agents actually working with them to actually help them. So we actually done a lot in our program. So I must give our program A some kudos on that. So we are actually doing a good job on that.
It's so great that you have that qualitative piece, right? Because we've spent a lot of time in our series so far talking about quantitative data gives you a lot about the face of a problem, but if you want to know what's really happening, you have to have that qualitative data. Right. And when we think about how our type of organizations, like even, I'm really interested in hearing Melissa's perspective from Legacy. When we think about what our agencies do, it's like, hey, well, we don't really control the medical care, so what can we control? We can collect all of this information in whatever way we can, in a sane, practical way, right? Because like as a person, you definitely know what it feels like to be over-surveyed. There's a lot of opportunities. Bridget, what would you like to share?
I'm Bridget. I work loss to care at Amelia Court, and I think one of our biggest issues is our homeless population. So we need to put a plan in action, a plan and an action together to grab that patient.
When we think about social determinants of health, I've really appreciated the way that we've changed the way that we talk and think about this, right? Food is medicine, period. Housing is medicine, period. So thinking about the work that we can do with the folks that we have in our fold, like who are in our housing programs, part of our case management, there are lots of things that we can do to assess whether or not our system meets needs. Even if my agency is not responsible for the medical care, it's really important, like overall, do we meet your needs?
Yeah, I would think it would be a lot helpful if we could get some type of communication with outside vendors as well as they meet with the patients, and we can collaborate more with them or try to get in touch with them. It's really hard.
So that was going to be one of my other questions is, do you have a sense of where your clients get their services within the service system? Or is it kind of like, for some, but you're not really sure for others? And, what's that like?
Well, they have these homeless shelters, and they use a lot of the home buses. So we can communicate that and we'll be on track. We can get them back into care. Fabulous.
Melissa, I'm not sure if you had to step away, but I would be really interested in your perspectives on this from your organization. And you may be muted. Sorry.
Yeah, all help is great to get.
So you're from, you said Amita Corp, Bridget?
Yes,
okay.
lost to care.
That's part of Parkland, Mark.
That's Parkland. Amelia.
Yeah, that's Parkland.
Well, your colleagues are in the other room talking about continued, but I think, I really am glad that you're here, Bridget, because there will be, while y'all are focused on the intervention for continued, folks from Legacy, from the other organizations will be reaching out to you, ASD will be reaching out to you to ask some of these questions that, we were just, discussing. And I think coming up with, so a lot of times providers in this group would likely feel like it's hard to work with the clinical folks because they don't answer our questions in a timely way when we ask. But we just heard from you, and I'm really glad that you said that. The clinical providers have the same perspective about us and our agency. Why ain't you be answering the phone and returning? When we ask a question about our clients, like we really appreciate, that response. So I think that it's really cool to think about this two-way bridge that we're building. And that will be one of the things that, Angie's team and Jamie and I will be working on with you guys an awful lot is, what is the hang up here? And how can we kind of untangle the knot so that we're able to have these conversations? because
Right.
this information is you're going to be your starting point, right? Like you'll have whatever clinical information that you have, whatever care information that you provide that's not clinical based on the services you actually provide. And then we're going to have to supplement the pants off of this with, probably some survey information or focus groups. Sometimes survey is going to be better. Sometimes focus group is going to be better. Sometimes there's something that we can do called a key informant interview, where we're able to identify, just a couple of people that fit a very specific type of patient that we serve, and we'll ask 2 or 3 people from each background, so that we can make sure that this isn't just a one-off perspective, right? That, because none of us represents our full umbrella. We're all intersectional beings. Hey, John, what are some of your thoughts for the dental program? Because you're a little bit of like the odd man out in this group, because while you're very clinical, but you're also not the health services clinical.
We work probably more closely with the health side than we do with any of the support service side, though, because of just the requirements that we put on ourselves and that the program puts on us medically. My thoughts so far are, I have our electronic data, I have our health records, I have no-show rates, and I have all those things, and they're very similar to what we get out of our EHR. And we have a very robust ability to pull data. But I don't have a lot of data to tell me why people are missing appointments. I have a lot of anecdotal conversations. I've had the patients tell me why, but when it comes to data on actually finding out why, and then being able to stratify our patients in a way that'll make sense, I don't think I have that. And I'm gonna have to figure something out.
Yeah.
I can stratify. The problem is the data is in 2 different places, because some of our data is in Aries and some of it's in our EHR, and being able to tie them together is going to be very, very difficult.
Yeah. So how do you do that hopscotch with the data and different databases, and all of that? That's definitely something that we'll be able to explore as we get further into this, and that we'll be doing probably one-on-one with you. One thing that you had mentioned, I think, is really important regarding data itself. We try to be evidence informed. We try to be, robust in, kind of having some type of research basis to what we do, but it's still quality. So it doesn't need to be perfect. So the thing that's nice about working in quality projects is that having conversations with some clients, if you just like back of a napkin or on a scrap piece of paper, write some perspectives, or based on your own conversations you've had with clients so far, you can kind of come up with a checkbox system. What are the things that are most important to you, or what are the main factors that have, prevented you from coming to appointments in the past? And then you can kind of just quickly test out a new survey, and that becomes your interview tool. Not that you ask the same questions to every person. I mean, that might work for you, that might not work, but it's sounding like what you would do is create, based on your expertise, you make a checkbox tool, and then ask a couple of people who meet certain criteria or from different backgrounds, so that you have, a sense of how there might be variability within population groups, because then you can take that information, to your partner organizations in the field. We find that people miss appointments for these reasons. What are the reasons why you find people miss appointments? And that might be an opportunity to work together on something. You don't have the van, another group has the van, so like working with 3 groups, like the van plus the 2 services, the most important clinical service or whatever services for trans folks, it's usually hormone, and how you can make it so that the van stops to you on the way. But whatever works. There are 1,000 different potential issues to unravel, and then 1,000 solutions to each of those 1,000 issues. So it's all about being sane and practical and measured, understanding we can't be all things to all people. We'll have to limit ourselves to 1 or 2 root causes that we really want to tackle, and work that way so that we don't drive ourselves crazy. We have to end in just a minute, but I'm just curious.
Well, did we ever get Melissa? I wanted to hear from her. I work with Melissa. I'm doing a presentation on how you can achieve a better rapport clients with their healthcare providers. I'm doing that for Melissa coming up in May. I was hoping that she would, I guess she's on 2 or 3 calls at one time. And I see our time is about up. Okay, so I guess you're not here, huh, Melissa? I was asking you to come off mute, but it's too late. It's 11:24.
Yeah. Here, let's send the notice. So we'll wrap up in about like 45 seconds. And you know, Helen, if maybe Melissa can speak to this like another time, it would be really interesting to get her perspective. But real fast, are any of your organizations involved in Create Equity or in any of these other, do you have a project already going on that's related to return to care?
Well, the Ryan White Planning Council, I'm a member of the Evaluations Committee and the Needs Assessment Committee and the Consumer Council Committee. So we do have projects in play. We're having a presentation also in May. So we just continue to do projects that try to help people living with HIV be more active and deal with health care and the endemic misinformation to give them true information that they can act on.
Wonderful. Well, it sounds like the Planning Council is going to be pleased as punch to hear about this project and all the different things that we do and learn through it. So thank goodness we have you on the line, Ms. Helen, and for being such an excellent stakeholder. Okay,
it's time to go.
So let's just take a moment. I'd love to hear just really quickly what folks had to say in each of these groups. Angie, Regina, and Julie, if you could just provide like a 15 to 20 second, 30 seconds maximum debrief of where folks are at and what some of their next steps might be.
So I'll go ahead. I was in group 1, I believe.
Sorry.
We need to, that's okay. So we had an overview that feel like it's going to need a little bit more training, not only for the staff of the agency, but those individuals, even maybe bring on some consumers to get some basic 101 training. Yay, yay. They're excited about that. And getting an opportunity for the, this will be an opportunity for the agencies, not only to see what are the challenges on the care side, that there never really been this deep diving on the care side. So yeah, looking forward to that as well. Jamie, did I miss anything? And that's my 30 seconds.
All right, Regina, thank you so much.
Oh, we just quickly touched base. There was some good information. They talked about some of the challenges they have. Some of the medical providers have some of the same challenges that the non-medical have as far as communication among providers and referring and following up on people back and forth. Some data issues and some data being in Aries and some data being in the EMRs and not being able to pull all the data and match everybody up to identify disparities in different areas. Also lots of success, lots of good projects and surveys going on at different organizations where people are getting their needs met and following up on feedback that's been given to how to improve services. So that was some of the feedback that we got.
Wonderful, thanks, Angie. And Julie.
Sure. So in my group, we had Prism Parkland and HSNT, our Health Services of North Texas. Prism shared how they are still working closely with continued to ensure that it can connect with their EMR, or at least trying to figure out the best, or what is possible. They are also vetting it internally with their internal staff. They talked about some of the 2 different populations that they're going to be focusing on and trying to help and reach. One of those would be those that are transportation challenged and internet challenged, right? So that's one group that could benefit from this. But then there's another group that might need a little more support with folks that are just truly technology challenged to begin with, right? So they might need like a case manager and continued support to help them, like a navigator until they get used to the system. And then talked about how excited they are for the potential of this project. They are also going to focus on 2 areas. One of those would be women who just recently or within, a couple of months delivered new babies, as historically their data has shown those women tend to fall in and out of care, especially after delivery. You might not see them again. And I also can vouch for that. In my experience, I've seen that same. And so giving them a tablet so they can still stay in care from their home using telehealth. And this can also be accessed for their mental health needs. And then they're going to start with a small sample and see what they learn and then grow that out. They're also excited to use this to increase usage of their patient portal. And they are going to, the other population is folks with substance use disorder. And they have worked with Continued to make sure Continued has all the apps that would support those clients, including the Ryan White eligibility and some other apps. And then they're going to have 2 staff members have 2 of the tablets so they can help teach the clients and interact with the clients. I hope I didn't misspeak. Those were just my quick notes. So, and we didn't get to HSNT. We ran out of time. I'm sorry.
Well, it's fabulous, though. I mean, so from what I'm hearing overall is that we have a lot of great momentum, and that folks are looking forward to kind of talking with us to identify what next steps they have for training, what opportunities they have to shore up their data, and as far as the continued implementation is concerned, we'll be able to continue providing some support around that as well, which is absolutely fabulous. I see that we are now over time, so I just wanted to remind you what Jamie had mentioned. We have a couple of different sessions coming up in this series. In June, we'll be talking about identifying change ideas. So we're going to be hearing from you what your aims are and presenting back to you what everyone's aim statements are. And we'll be sharing in our workshop, in our breakouts, what some of the change ideas that we're considering implementing based on our root causes analysis. But we won't expect you to be making those changes at that time. By the time we get to August, you will have started implementing some changes. And so you'll have some data to share back with us, and we'll be sharing that with you. And by the time we get to November, we're going to be having a good sense of what folks are actually doing and what progress they've seen, so that we're able to share across each other and really identify how to strengthen our healthcare neighborhoods and pockets of our service system in Dallas. And then, as Jamie had mentioned, we're both really excited for the poster symposium that we'll have in January, where you'll be able to feature your work all on one page. And then hopefully that sets you up really nicely for conferences and for papers and other things, so that you get some of that limelight that you deserve here in Dallas for all of your great work. So thank you so much for staying over. I am going to launch our evaluation. I don't know if there's anything that Oscar or Sonia or anyone else wants to say in closing.
Well, I would like to add the last detail before. The evaluation is important. Please send us that evaluation. That's for the training. And but I want to thank for the participant of this project and everybody interested and involved in this. This is a new initiative. This is something that will create new ideas for the county and for the Ryan White, and at the end, for the client. That's our main goal: how to serve better our population. I mean, we thank you so much for that. And Christina from HSNT, we're gonna email you this afternoon about that and keep you up to date on this one, because Louise was on top of that, and probably you haven't get to that point now that you have her spot. But again, we are looking forward to keep supporting you in every question you have in developing the process of the QI. Angie, Regina, and myself, we are here for you guys. Thank you.
All right. Thank you so much, everyone. And thanks for responding to the poll. Have a wonderful rest of your week and a beautiful day. And we'll see you next time.
Bye,
Bye,
everyone.
everyone.
Bye, everyone.
Bye-bye.
Thanks for joining us, too. It's great having you.
Thank you so much. It was good to see everyone.
Thank you.
Bye.
Bye.
Bye.